as an unresolving UTI, patient constantly leaking. Overdoing water intake is the biggest problem when it comes to bladder issues. So I generally say 10 glasses a day. Many times these patients they have a bad fall in the bathroom while rushing. They end up in an orthopedic department with fracture of femur or ankle or something like that. So most of the time, in fact, I will say majority of patients come to us with mixed incontinence. Most of it. 70% of incontinence cases are mixed incontinence. Out of them, only 20 to 30 will be pure stress incontinence, and only 10% will need surgery. And the thing is, if patient does not learn Kegels, the effect is not.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Topic today is urinary incontinence, and we will start with infections. As you know, acute incontinence is a feature of infections, and therefore, even though this may seem a little out of place to some of you, we will first discuss UTI and then go on to discuss the standard SUI, overactive bladder, etc. So, Dr. Naik, what are the commonest reasons for recurrent UTI in the young?
Yeah. First of all, thank you, sir, for having me here. And to your first question, that recurrent UTI in young women, I will be happy to elaborate on it because many times incontinence presents in these cases as an unresolving UTI, patient constantly leaking. Looking at the common scenarios in today's world, one is definitely poor water intake in our young ladies, not taking enough water. Second is holding bladder for long hours, whether it is are they busy in binge watching Netflix, or maybe they are busy in their desk jobs. They are constantly on calls, let us say corporate jobs. So if I'm taking young as less than 40 years, being young, then a lot of these women are either traveling long distances in Mumbai, they're taking long hours of train travel, road travel, and lack of public washrooms. So, in general, there's a tendency to hold urination. Once they hold, the bladder gets always gets a colonization with various bacteria, and these two I find very commonly in our young women. Along with that, period pad hygiene and other things like menstrual cups, post sexual intercourse UTI. So these four largely take over in young women. These causes.
What is the, you said adequate fluid? What is the amount that is adequate? Is it
Yes.
body weight based?
Uh, this is one question which is always very intriguing because usually we have a tendency to tell women that drink more water, and there is no definition of what is more and what is less. So it is all based on a person's body profile. A very thin lady, a very obese lady, a athletic woman who is spending a lot of time in gym. Overall, I generally say keep it around 2 liters. For a lady who is largely in home, in an air conditioned, comfortable space, somebody who is going outdoors on daily basis in sun, I say increase by 500 ml. Overdoing water intake is the biggest problem when it comes to bladder issues. So I generally say 10 glasses a day, each glass being 150 to 200 ml, turns out to around 2 liter. Make sure you drink every hour. Don't, let us say, take big portions and then don't drink for hours, which is not the right way. And don't drink in the night. Let your bladder rest.
Anything related to sexual activity? Any precautions there if you get post sexual activity?
Oh yes, sir. Like honeymoon cystitis is a normal term. It's an established term that immediately post marital phase or newly started sexual intimacy, post intercourse UTIs are very common. Now, what can help is emptying your bladder before the intimate act and immediately post intimate act. Keeping the hygiene better is important. There are times when we do dig into the quality of the sexual act. A poor foreplay more friction, too rushed, too rough can be a trigger for many ladies. Many times there is an undiagnosed yeast infection which keeps getting triggered due to friction. Sometimes it is condom allergy, sometimes it is lube allergy. So there are a lot of layers to the post-sexual intimacy UTIs. Many times we have to put them on prophylactic antibiotics for initial 3 months of marriage.
Prophylactic as in single dose before intercourse.
Yes, yes, yes. So there are like our family physicians are hearing. So I just tell them either take single dose of nitrofurantoin post every intercourse and maybe cover it with 1 dose of alkalizer next morning. So in next 24 hours, again that friction, the mucosal epithelialization re-happens. It happens again and patient settles. But yes, it can be very disturbing for a newlywed couple many times.
Recurring infection in the elderly, which is of course a greater problem. What are the causes, and is it always infection, or it can be something else mimicking an infection?
Yes, sir. Like we discussed about young being less than 40, let me take a perimenopausal age group 40 to 50 and then the postmenopausal after 50. Now, this is the group where ladies sometimes have very bad UTIs again and again, largely because of hormonal changes, atrophic changes in the vagina, again causing mucosal abrasions, irritation, and many times the symptoms of UTI. They look like UTI, but they are not UTI, but they are overactive bladder. So repeated episodes of frequency, urgency, and we all don't want to do repeated urine tests. We just give antibiotics, and later on you realize that all the urine tests actually are coming negative. While the symptoms of frequency, urgency, poor flow, burning, they're not settling, and that's the red flag that it's not UTI. And that's how a UTI case turns into a case of incontinence and overactive bladder.
Okay. What about vaginal atrophy or urogenital atrophy? Also an important factor. How
Oh,
do you
yes.
recognize that?
So this when we take history on with the patient and we can see that age group, we know that vaginal examination is going to show us a lot of signs, loss of vaginal rugosities, and it is indicating atrophic vagina. Also, these patients will have something else also, like there's a constant rashy feeling below. They do give history of, there is a constant rash-like feeling, burning, pricking, so there are some kind of vaginal symptoms at rest also. So that is one hint. Second, if they are sexually active, many times the women may not have stopped periods, but in sexual activity, they immediately pick up that the dryness is there. The lubrication is not as much. Now, these are the hints which tell me that there are definitely atrophic changes happening in the vagina. And these are the cases where, urogenital syndrome is identified, and vaginal estrogens definitely play a good role to help the patient.
Can we here just talk about the treatment of and or the prophylaxis of recurrent UTI in the elderly before we move ahead with other causes of uh, incontinence?
So, for recurrent UTI, one thing I really insist on that our family physicians can do at their level, and I always tell them and teach them that you do urine routine cultures as per requirement, but one thing never misses doing a ultrasound KUB with pre-void and post-void residual urine. Now, if residual urine is high in an elderly lady after 50, it indicates somewhere bladder outlet obstruction. If there is an obstruction, high residual urine, this patient will not improve with prophylaxis because there is always a baseline high urine inside. These cases need cystoscopy and urethral dilatation. So identify them early. Anybody who is more than 5 years of menopause, perimenopause, then definitely there is always a possibility. Rule it out early and then you can work around with various antibiotics. So, prevention generally, I suggest give it for 3 months. Once you have achieved a clear urine routine, once put them on prevention for 3 months, and every month make sure one urine routine is clear so that any building up pus cells you pick up earlier and then change it to therapeutic. So, surely prophylactic regime works wonderfully for these patients.
What are your first, second, or and third choice prophylactic antibiotics for 3 months?
Sir, if given a choice, I always choose it by the culture sensitivity. The first culture sensitivity, it is if it is in my hand. If let us say I don't have any culture and history is very much suggestive, my first choice is always nitrofurantoin. It's a age-old antibiotic. Tolerability is good. Just 1 dose every night, and I add vitamin C with it. so that the concentration in the bladder becomes much better. And I tell the patient, don't drink water in night so that the medicine gets concentrated in the bladder overnight. So the adherent E. coli, they are attacked by the good concentration of nitrofurantoin overnight, and then in the morning, daytime, I give them an alkalizer to sort of help to pass urine, flush it out, whatever. So this regime has been working very good for me, and when I give it for 3 months, thinking that the sticky bacteria, the E. coli, which are adherent to bladder mucosa, they get targeted. Overall, the response rate is as high as 80 to 90%, but yes, 10% patients still have relapse, and we all sort of struggle with such cases.
Uh, as you said, there is something called urogenital syndrome. What we used to call atrophic vaginitis is probably now renamed urogenital syndrome of menopause. In these
Yeah.
cases, you use estrogens locally. Uh, how is that used, and can the family physician prescribe?
Oh, yes, sir. The only thing is, I say, as family physicians, they are our bridge to the patient. The first thing is make sure you are not giving it to a patient where it is absolute contraindication. And that's the most beautiful part of it, that at their level, they can much better do it, better than sometimes else. Anyone who has history of breast lumps, anyone who has undiagnosed vaginal bleeding or is in like perimenopausal menorrhagia or DUB cases, anyone who has very high sensitivity to estrogens, because once you apply it, the patient starts feeling sometime tingling and numb, too much of arousal symptoms can happen, hot heatiness can happen. So they can really filter out which patient we should not give. Any cancerous cases, past history of breast cancer is one of the most prominent. Now, if you want to start, please start it. Tell them a clear way that the medicine comes with an insert, with a measured inserter. So, pushing it inside the vagina, the creams, estrogen creams, has to be very graded. That 15 days every night, then you make it intermittent twice a week for next 2 weeks, then you make it once a week for 3 months, and then do stop it. So they are very good in regulating because patients are very well connected with a family physician rather than us. So once they insist this regime, they understand that it is not for a lifelong use. So the best way is give intermittent, a loading dose, 15 nights every night, then make it once a week or maybe twice a week, and once every Sunday for 3 months, but then stop after that. The effect will last for almost 6 months, and that is good enough for us.
What is the role of other prophylactic medications that some people give, like cranberry extracts or D-mannose? What is
Yes,
the
yes.
role of those?
Yes, sir. Recently, a lot of research is coming in here that are we can we target the sticky bacteria without providing antibiotics, or can we increase bladder local immunity? Definitely, cranberry has certain elements. The only thing is natural ways of eating cranberry, you cannot really eat that much. Plus, a lot of our old patients are diabetics. So, cranberry juices, the way the commercial products are there, definitely I don't suggest that. Rather than you can choose some good supplement which has combination of cranberry plus, let us say, D-mannose. D-mannose is supposed to break the fimbria of E. coli. It has a proven role, scientific role, that it sort of detaches all the sticky bacteria. So these days, a lot of pharma companies have combination medications where there will be some D-mannose, some cranberry, some potassium citrate, or the plenty of commercial pharmacological products available. I do put them. Patients, let us say, once 3 month NIFTAS nitrofurantoin is done, and they're still not confident. So at least I can start it. So a
Okay,
lot of over-the-counter preparations for cranberry D-mannose are available, and I think no harm in putting a patient on that.
got it. Let's now move on to incontinence of the chronic variety, especially in the elderly. Can we start with SUI, stress urinary incontinence? Typical patient. How will the typical patient present?
So stress incontinence is a spot diagnosis. You do not need a specialist to diagnose it. Any family physician at their own level can pick it up straight away because patient clearly gives a history. I leak urine when I cough, sneeze, laugh, jump, or I change position, or when I want to run, or if I carry heavy things. So there will be always a postural element involved in stress urinary incontinence, which is not there in other kinds of incontinence. SUI does not need any kind of fancy tests or sonographies or urine tests to be proven. It is simply a clinical spot diagnosis, so it's very easy to be picked up by any physician any point of time.
What is the epidemiology or the incidence? For example, is it more in the female, in the male?
Yeah.
Uh, any age preference, age predominance?
So SUI overall, when I see being a urogynec, I'm seeing only female patients, but I'm very sure because of the pregnancy related changes, because of the menopausal changes and the hormonal changes throughout the years of life of a woman. As far as literature says, SUI is 3 times more common in women than men. Just the fact that male urethra is much longer. The urine leaking with a cough, the chances are pretty less. While male deal more with prostate issues at a age more than 50 and 60, women deal more with leakage issues. So, for a woman, if I say overall prevalence of incontinence can be as high as 60 to 70% on an average in our own surroundings.
Okay.
Means any lady suffering from leakage at a given point of time in life will be as high as 60 to 70. At least once in lifetime they will face that is so high. Whether they will reach to clinic is a different thing,
Mhm.
because many of them accept that it is with age, it is normal. It's okay to put a little bit panty liner. Plus, our Indian clothing ways, saris and kind of dresses, they are very protective for a woman's dignity. So even if somebody leaks, it doesn't really sort of alarms them. Oh, I need to go and see doctor. Now the awareness is increasing. Therefore, our literature is gathering more data. But I still say in any basic gynec OPD, at least you will find 30 to 50% cases related to incontinence.
And for the family physician, it might be important to elicit the history by a leading question so that the patient
Yes,
comes out. Yeah.
definitely,
Uh,
sir.
is there any medical treatment for SUI?
Uh,
Pharmacotherapy?
Yeah, the pathophysiology of SUI itself is because of weak pelvic floor muscles. So when the
Mhm.
urethra moves, then we know it is a pelvic floor problem. It's basically the dynamics. If this is the bladder, this is urine. You cough, you sneeze, you laugh. It is moving. It is hypermobility of urethra. So medications have a limited role in stress incontinence.
Correct.
So only thing which we can help is either with Kegels exercises or surgery. Though there are some medicines like duloxetine. It is supposed to help by improving urethral tone. Can be used temporarily, but the side effects, the sedation, overall drowsiness is higher, and not many physicians will be comfortable writing duloxetine as a long-term basis. So it cannot cure. So somewhere
Correct.
medical management stays to vaginal estrogens only and teaching the patient.
How does one patient learn Kegels?
Sir, to teach patient Kegels is like a mastery which a physician learns slowly himself or herself, because vague description of Kegels that you try to hold urine when you pass urine is how traditional old time, even we as gynecs were taught the same way, that tell the patient that to stop the urine while urine stream once they are passing urine, which is totally wrong. What happens when the body is trying to pee and release urine? Your muscles are supposed to relax, and at that time with high urge, if you teach them to squeeze, it goes totally against, because they end up doing reverse Kegels and pelvic floor goes in discoordination. The best way is to internal examination, internal pelvic examination, PV examination, and see which muscles she is contracting. Now, for that, you will need the patient to either go to a gynec or a pelvic floor physiotherapist, or send to us who are vaginal surgeons or urogynecologists. A simple way is to tell them to imagine that they are very urgent in passing urine motion, and how will they control, how will they squeeze? If they can do that while sitting on the chair, like I am sitting on the chair and the buttocks are touching the chair, and squeeze it in, and you actually feel that the anus and vaginal muscles are lifting up. So, unless there is someone who can give them feedback by an internal examination, 50% of women do not identify it correctly. And that's where you need us. That's where the role of pelvic trainers come in.
Are there equipments like I've heard of
Yeah.
cones, vaginal cones? Are they used
So,
here in India?
yes, yes, yes. We have all these things. Usually, these are the tools to a pelvic floor physiotherapy unit. So they will have vaginal cones, they have vaginal rings, they will have some biofeedback devices where when the patient contracts the muscle, they can actually see the graph going up and down on a screen, on a interface. Lately, their apps, various apps are being developed where you put a sensor near the vaginal muscles and the app will show you how much you're contracting. And there are many devices which can give patient a feedback. Many times in low cost setting, we give mirror. So we put mirror at the perineum, give the handle of the mirror, a handheld mirror, to the patient and show them. Then once they squeeze, how the muscles lift up. So there are a lot of tools. Vaginal cones is one of those. You give small cones which have different weight and ask them to hold inside and then walk. So slowly it becomes a weight bearing exercise for the pelvic muscles.
Correct. Uh, so pelvic muscle floor exercises are chiefly used in SUI, not in other forms of incontinence.
No, sir. I think Kegels and pelvic floor rehabilitation itself is a big entity which can help not only in stress incontinence but also in overactive bladder. Because in a lot of overactive bladder happens because of anxiety. Once you are anxious, you are thinking of washroom, you just cannot control, you will rush. Now that is the point where a Kegels help a patient to hold back, that oh, I can hold. So it actually suppresses those non serious contractions of bladder, so the detrusor overactivity can be suppressed by a good Kegels. So it has a role in overactive bladder also, and in other incontinence also.
So, on that note, let us go to urge incontinence, which is also called overactive bladder. Can you tell me a clinical case presentation of a female with urge incontinence?
So almost 70% of incontinence cases which goes to a physician, family physician, are of overactive bladder. A typical presentation will be a 60-65-year-old lady wakes up in the night, want to rush to toilet, on the way she leaks urine and just cannot control. Many times these patients they have a bad fall in the bathroom while rushing. They end up in an orthopedic department with fracture of femur or ankle or something like that. And many times I get referrals from them. If you really dig in the history, they were wanting to reach washroom on time and they were not able to hold urine. So the typical history is that I cannot control. I go and rush for washroom. I'm always looking for the toilet. I go to a mall, I look for washroom. I cannot wait in a queue. Invariably, I have to tell people that mujhe jaane do, means I want to jump the queue because I cannot control. Many women will have very embarrassing episodes that while being in lift, reaching to the house, and they were so urgent that they leaked in a taxi, in a lift, or they will say the moment I am at the house, I'm opening the lock and key and I will just start pouring. So the typical symptom is urgency, that there is a very strong urge to rush. They will interrupt their cooking, they will interrupt their TV show, and they will really rush to washroom. Often they leak. This is most of the time the commonest way they present.
The condition is called urge incontinence, which you explained why. It is also called overactive bladder. Why is it called overactive bladder?
So we have seen that all these patients, when we do urodynamic studies, we see actually in a significant number that the detrusor muscle is contracting at very small filled volumes. Usually, a lady can hold maximum up to 300, 350 ml of urine and should be able to reach washroom on time. But these bladders, which are overactive, we have seen that the detrusor keeps on contracting unknowingly without the intention of the patient, and even with a volume as small as 100 ml or 150 ml inside, does not let the patient sit. Now this overactivity can be a result of previous recurrent UTIs, when the bladder has got so irritated with repeated infections that it has gone in a chronic state of irritability. So it keeps on telling you go, 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 does not let the patient sit. Added to it becomes element of anxiety plus weak pelvic floor. It cannot hold even with the normal urge and they start rushing and they end up leaking. Problem happens where a physician tells that you drink more water, it is infection. And that's where it goes against us, because the bladder who is not able to hold 100 ml suddenly starts getting a lot of water and they keep on leaking more.
But these patients of overactive bladder, they typically do not get infection recurrently. Is that right? Because there is
Sir,
no residual urine.
either infection will be secondary to wetness, because they're
Okay.
constantly on diapers. They're always wet below. The skin starts getting excoriated, the ammoniacal smell. They get so scared, either they will be sitting in wet clothes, and that becomes the secondary problems of UTI.
Mhm.
So it becomes a vicious cycle. Repeated infections giving rise to overactivity, wetness leading to vaginal irritation, and again keeps getting to contamination.
So, chiefly the overactive bladder is would you call it an idiopathic condition more than a secondary condition?
Yes, sir. If you ask me what is the cause of overactive bladder, largely the cases are idiopathic. We don't know why it triggered in. Many times it happens for a short interval, just give 2 months medication, it settles, never come back. There are patients where they will keep on repeatedly they will need anticholinergics. They need medications. The moment you withdraw, again it starts. Many times, in fact, most of the times, there is no reason if I can figure out what triggered it. Difficult.
So on that note, as everybody knows, the trusor muscle basically contracts when you have a cholinergic stimulation and relaxes when there's a sympathetic stimulation. So we give anticholinergics or sympathomimetics. So can we talk a little bit about the pharmacology? What
Yes.
are the anticholinergics that you prefer to give, if at
Yeah.
all?
So there is a set of medications. Most of the urologists, gynecologists revolve around that. I can bet all family physicians can simply write them, but just start with low doses. Giving the names first, and my first line is solifenacin. That's the most commonly one I used. Comes with dose of 5 milligram. You can increase it to 5 milligram twice a day. You can make it 10 milligram twice a day. Just make sure she doesn't go in retention. So if somebody has high residual urine, don't give these anticholinergics. Second is tolterodin. It is available in 2 milligram doses for a very thin slim patient. You can go up to 4 milligram. You can give 4 milligram twice a day also. Avoid going more than that. It comes with 4 milligrams, so slow release also. Then comes Darilong, Darifenacin, 7.5 milligram. The good part is that it does not cross blood-brain barrier. So if your patient has a lot of dementia, Alzheimer's feeling, stroke patients, so my preference in those cases is generally Darifenacin. At least theoretically, it doesn't cross blood-brain barrier much. Now, oxybutynin is the first line old primitive one. A lot of
Yes.
side effects in terms of dry mouth, dry eyes. But yes, if refractory, I sometimes do switch to oxybutynin. The most latest is Mirabegron. Mirabegron
That
25 mg, 50 mg. They are the ones which are coming with a better side effect profile. Combination of Mirabeg and solifenacin is also available. My preference is always to start with low dose and then titrate based on the patient's response.
Yeah, one thing that Dr. Sarita said, and I missed asking about it, residual urine. So one of the key features of overactive bladder would be a lack of residual urine on ultrasound. Is that right?
True. Yes, sir, because that's one thing I say 80% of urogynecology can be done on family physician level by only urine routine, bladder diary, and by ultrasound post void residual urine. 80% of my work, my physicians give me such beautiful cases by doing all this that it becomes so simple. If residual urine is high, then it is not overactive bladder. It is secondary frequency because there is residual urine because of an outlet obstruction. So the treatment is totally different. If you give
Mhm.
anticholinergics with high RU, it will further increase, it will aggravate. Patient will
Correct.
keep telling that I'm not improving. In fact, my urine doesn't come out anymore. Plus, UTIs will increase. So be very early in your practice to order a post-void residual urine, and you will realize so beautifully patients respond to the right medication.
So again, to remind all of you that uh, overactive bladder is chiefly defined as detrusor hyperactivity, where the residual volume is nil almost on ultrasound, and patients get the urge to pass urine at very low volumes of bladder. Uh, you spoke about some anticholinergic drugs, and then you mentioned one sympathomimetic drug, that is mirabegron. You did not tell us the dose of mirabegron. What is the dose that you typically prefer?
Sir, again, if a patient is very obese, I can start with 50 mg. Otherwise, 25 mg is available. Sometimes I add Mirabeg S, which is combination of Mirabegron on solifenacin when I know that one medication is partially effective, but tolerance is not so good. So I can add the other one. So 25 mg to start with, once a day or once a night, based on it is frequency troubling or nocturia troubling. If it is only in night, give only in night. Then you can go up to 50 milligram twice a day. But let me tell you, if you use these medicines, please watch residual urine. Patients may go in retention with these medications.
And the side effects of the anticholinergics, of course, is especially commoner in the elderly when they will get
Yes.
imbalance, dry mouth, constipation, etc. So,
Yes.
in the very old female with overactive bladder, should we prefer mirabegron over the anticholinergics?
Yes, sir. The only problem with mirabegron is that it increases blood pressure. So if your patient is on antihypertensives, Be very careful if she suddenly starts complaining after giving mirabegron in 2 days that I'm having headaches. Most probably her BP has shot up. So I have
Correct.
got one case where I have to withdraw mirabegron, though it had really worked wonderfully for urine symptom. But she kept on saying headache, headache. And I said, just get your BP, and it has shot up to 160/90 because of mirabegron effect. So then I
Correct.
have to withdraw and put something back. So you need to watch carefully your patients.
So this was the pharmacotherapy of overactive bladder. Is there any non-pharmacologic measure? You said Kegel may help here.
Yeah.
Anything else? Any precautions or yeah that the patient can take?
So the biggest thing is managing water intake, because that biggest belief of drink more water and water is a detox, and then let's have some kadas and smoothies, and these days green diets and plant diets are all water based. Lot of fruits they will try to eat thinking that it is helping in there, and the typical belief that morning I take 2 glasses of warm water, it helps me to flush the motion. That's very normal in our own house, all of our own households. But what happens that just bombards the kidney with a lot of water, and can be a reason of triggering that overactivity while the bladder is just trying to cope up, but it has got distended with 500 ml water, which is like half a liter. Imagine half a liter of cold drink coming in your hand and how heavy it can be. A old lady with this volume, definitely it's not going to work, and that's where our main challenge is to bring lifestyle changes. That's the biggest thing. The water intake. Same is in the night. Diabetic patients or nocturnal polyuria patients, invariably the urine formation is in the night. They definitely will wake up twice. The moment they wake up, they pee and they want to drink because they are thirsty. So these things really make a huge difference in management.
Uh, will caffeine or alcohol also hamper the problem?
Oh, yes, definitely. Caffeine, nicotine, tea, chocolates, beer, sometimes wines, all these things are considered bladder irritants. For younger population, smoking. Definitely these days, vaping, smoking, all kind of drug abuse is very casual in college students. And when you talk to them, you will find that they are having 20 sticks of cigarette in a day, and vaping has no end. So all these things eventually they affect bladder. Same is with tea and coffee. This trend of having huge mugs of Starbucks, big, portions. Nobody want to have a small cutting chai or a tea. Or, it has become a status symbol to carry this big of coffee mugs every day. We actually are overloading bladder with these caffeine and nicotine things. So
Yeah.
surely they affect. Yeah.
Is there any role of in resistant cases of overactive bladder? Any role of Botox injections?
Yes, sir. Yes. So the thing is, if managed well and early in a case, I will say our success rates are around 80 to 90% with anticholinergics, lifestyle, and behavioral. But yes, there are 10 to 20% patients for whom either medicines don't work or they give bad side effects. And in the end, what do we do? So few things for these cases which are more experimental with limited results but are proposed in theory at least. One is cystoscopy and hydrodistension, that in cystoscopy you distend the bladder, fill it with the saline and keep it there so that the bladder capacity becomes a little more, and that erratic bladder activity under anesthesia, it's sort of you overstretch the bladder and it settles. Works in 50% patients. 50% patients again after a month or so are back. Now here what else can be done? Bladder Botox is one of the new therapies, where Botox, being Botox toxin, it blocks the cholinergic receptors, just like it works on the facial muscles for Botox therapy and all. It sort of create a paralytic environment in the detrusor. So overactivity subsides. The only thing is, once injected, you cannot remove it. And if, let us say, the bladder becomes atonic, the patient should know intermittent self catheterization.
Oh,
So that kind of thing, receptivity to our Indian patients is a little low. That what if I cannot pass urine? So I cannot catheterize myself. So only few cases do agree, and the effect of, let us say, the overactivity, the good effect, still will not be permanent. After 6 months, they will need again a dose of injection. Yeah.
uh, yeah. So that was overactive bladder. So we have those who have come in late. I think the match of Indian Australia has ended, and some of you have started coming in. I'm talking to Dr. Sarita Naik. She's a urogynecologist in Mumbai, and we are talking about incontinence. We have covered urge incontinence, that is overactive bladder. We have covered stress urinary incontinence, and now The third, the more difficult kind of incontinence is your overflow incontinence. Uh, what is that, and what are the causes?
So, overflow incontinence, I wish I could again figure out the causes. In my practice, it's difficult, but yes, diabetes is one of the biggest culprits. Long standing diabetic patients, spine problem patients, where there have been spine, let us say, fractures or compressions or discompressions, nerve compressions, chronically, they have been some back issues. They are the one who eventually end up some kind of sensory and motor dysfunction of bladder. So what happens? This bladder becomes like a flaccid state, like a balloon. It's lying just there. All the urine is getting accumulated. Neither it senses properly, nor it is able to squeeze properly. So what happens? Whatever urine is coming in, it is lying in that compartment, and after a point, the sphincters sort of give way. So it becomes a channel which is flowing from top to bottom. The bladder is always full while they will not have any sensation. Typically, these patients are poor in cognition, let us say Alzheimer's, dementia patients who have some kind of neurogenic problems, let us say post stroke patients, post spinal cord injury patients, these kind of things with some neuropathy features. And 30% are otherwise very well. So you can't even define is it really the reason or no. The history is that they're constantly on diapers. There is no sensation. They don't know anything. It is always flowing. They are always wet. The urine does not, they don't know when the urine is, the urge is there. And they're constantly leaking, constantly on the diapers. Difficult to treat. First of all, technically, we need to exclude fistulas. That is it a fistula related to a previous hysterectomy or a surgery? But neurogenic bladders are the most difficult cases to be treated.
So, as all of us know, diabetes, long-standing diabetes, called autonomic neuropathy, and one of the features of autonomic neuropathy is this neuropathic bladder. Uh,
Yeah.
Obviously, when it occurs, we have to give them support in terms of either pads, diapers, etc. Can you tell us something about the various barriers that we can use for leakage, or small absorbents that we can use?
So the thing is, people use their own things many times because not every family can afford daily three diapers. The
Correct.
cost factor becomes too much, and most of the treatment in neurogenic bladder happens around intermittent self catheterization. So we have to train somebody in the family to drain the bladder if the patient cannot do it herself. These bladders need to be emptied because otherwise the kidneys will start getting back pressure damage because of higher urine always inside, plus UTI will never be resolved. So either we teach the family member or maybe a helper or a nurse or a maid or a moshi how to catheterize under sterile conditions. Do it 3 times a day, keep the bladder empty. That actually reduces the leakage to a large extent because the volumes, big volumes, in 3 times a day you are relieving. And many times you will see if done properly, the sensations do revert back also. So there
Okay.
are cases where I had put them first on full-time catheter, permanent catheter, then withdrew the catheter, shifted it to intermittent catheterization, and slowly patient started passing urine also because she started getting the sensations once the bladder was decompressed. Looking at those where it is totally refractory, the leakage things, people use cloth pads, people use diapers, people use sanitary pads, or they will keep putting sheets. Sometimes there is like there are few things available on Amazon where the panty has a attached pipe, something like condom catheter for men. So there is a pipe attached to the underwear, and it is available on Amazon. Even I was surprised to see that these devices are coming these days, and it is connected to a bag, so there is no catheter directly inside, but whatever
Mm.
she is passing is coming through that hole. Practicality and reusability of these things are very questionable because infection rates become very high in these cases.
Correct. About clean intermittent catheterization, or CIC as we call it, what catheters do you recommend? What is the catheter used
So
for?
we generally give K90 catheter, which is normally available. Comes by name of urethral catheter. Yes, there are people who are affording, so they will buy, let us say, 3 catheters for a day and discard. There are some people who cannot. So there are some rural patients of mine who have got red rubber catheter. They just boil it every time in water at home in a boiler and or in a patila or whatever their household stuff. They clean it with proper antiseptic and reuse the same thing. And once in a month, they will just buy the other one. And the natural colonization of urethra has become sort of adjusted to it. So there are
Okay.
people who will reuse, but that then they have to be given that kind of reassurance that you need to make sterility, make sure the sterility of this particular thing. So in foreign and abroad, we used to find those kind of plastic or silicone coated kind of catheters which they will sterile at home and then keep reusing, and they're perfectly fine with it. If possible, at the moment in beginning, I give them use and throw disposable ones, K90 catheters for at least 3 months.
And if a patient is on a permanent or at least a long period of indwelling catheter, what do you advise? How many weeks of indwelling? Which kind of catheter?
So if the patient is motivated and let us say for some reason she has gone in acute retention, apparently looking like neurogenic after a surgery or something, if you put catheter for some time, I do advise that get the patient to us. We teach them intermittent clamping. If the sensation starts coming, I do encourage that let's try off catheter and see how much the residual urine comes. Let us say it is decided this patient will be on lifelong catheter, then we need to change it 3 monthly with a silicone catheter. The regular Foley's catheter cannot be put more than maximum 4 weeks, but I generally change even that in 3 weeks. I don't like it to be there longer. Silicone catheters, technically for 3 months, they say it stays, and every 3 months you have to change the entire thing with the bag. But still, the continuous catheterization, initial phases can have lot of pustules in the urine. Lot of times the recurrent UTIs, the catheter induced UTIs keep happening to these patients, and they have to be on long term antibiotic prophylaxis for months and months. Later on, then you have to keep doing repeated urine test and then talk to the microbiologist that which antibiotic we keep shuffling. Tricky and challenging phase for these patients.
Do you advise suprapubic catheterization to anybody who's on it?
Uh, So theoretically, yes, I'll say as our training says that suprapubic catheter is the best way of catheterization, looking at the cleanliness and the UTI index. But I'll tell you, a patient having a catheter below finds it more comfortable rather than popping it coming out from the top. So in female patients, so far I have not done it. But yes, most of our male urology colleagues and urology people, they do suggest suprapubic catheter as the best option. But I still feel in a woman, the chances of recovery, if given a good trial and a good care of like clamping, declamping, in between trial, it does work. So case to case basis, that suggestion can be considered. So theoretically, yes, suprapubic will be always the choice, but practically, I'll say that in practice, so far I have not done it. Most of our patients have settled with, temporary catheters and are off catheters.
So, just to recap, we have discussed acute incontinence in the form of urinary tract infection. We have discussed three kinds of chronic incontinences. One is stress urinary incontinence, second is urge incontinence, also known as overactive bladder, and the third is overflow incontinence, like in an atonic bladder. The fourth form is a mixed incontinence. Uh, Sometimes two forms can coexist. Which are the commonest two coexisting incontinence forms?
So most of the time, in fact, I will say majority of patients come to us with mixed incontinence. Most of it. 70% of incontinence cases are mixed incontinence. Out of them, only 20 to 30 will be pure stress incontinence, and only 10% will need surgery. Majority of it is mixed with largely urgency and control problems. That is, overactive bladder predominates in mixed incontinence. When we look at mixed incontinence, we always start with the part which is troubling the patient more. Let us say patient says I have control issues troubling more, cough happens only once in a while, that's not my really bothersome factor. Then we don't really start pushing for surgery for stress incontinence, which is TVT. We generally work for frequency urgency symptoms. But if she says I can reach to washroom most of the time, but my whole problem is I go to gym and I want to lose my weight and I want to exercise and I keep leaking the moment I carry a weight or I just do a jumping or squat, then the treatment of SUI takes over. So mixed incontinence is the largest presentation. It is the presentation based on the profile, whichever part we want to treat first.
You are a urogynecologist, so obviously surgery is an important aspect of your work. We did not talk much about surgery for incontinence. For SUI, stress urinary incontinence, which is not responsive to Kegels, etc., what are the surgeries that you do?
So traditionally, what we learned from our seniors was birch corpus suspension, which was done from the abdominal route. Now laparoscopic birch was also done, but I'll tell you as urogynecology speciality, what surgeries we do are much advanced and least invasive, and they are called mid-urethral slings. So what we suggest is, if let us say this urethra is weak and keeps on moving because of hypermobility, we put something called a tension-free vaginal tape like this, like a V. So this tape is a mesh. It stays below the urethra and comes out from the top at the retropubic area, and it holds urine pipe urethra like a sling. So it actually mimics pubourethral ligaments. And once it is in place, the moment patient coughs, sneezes, laughs, it's a biodynamic sling. So it keeps the urethra up. So it works wonderfully for patients who have pure SUI, where hypermobility is the reason. And it's a minimally invasive surgery, takes half an hour. Patient truly can be discharged in few hours, let us say 8 hours, though I like to keep for 1 day with catheter. There are no major cuts on the tummy, can be done on the spinal, does not involve laparoscopy. So efficacy being as high as 95%. And
Wow.
if it is suiting the patient well, then the result will be immediate. From the next day onward, because of the physical presence, you can immediately see the effect if it is rightly corrected, rightly diagnosed. So, urodynamics and all investigations together can filter which cases will respond best. And let us say, if more effect we are looking for, next 3 months, the fibrosis further enhances this sling. So, a lot of patients improve, let us say, 70% by within 1 week, and slowly over 3 months, aided with the exercises, the effect gets better by 90% plus, provided it is done in the right patient and not in a mixed incontinence patient or with a neurogenic patient.
Can you repeat the name of the surgery? What kind of
It
sling
is called
surgery?
TVT, tension free vaginal tape. Also comes by name of TOT, transobturator tape. Collectively, they are called mid urethral sling surgeries.
Got it. Um, any other more invasive surgery that is still being done?
So, birch corpus suspension is still chosen by a lot of laparoscopic surgeons, in which you go from the top and parallel to urethra, you put some stitches to lift it up. But there is no support below in that case. When these slings were not there, they came in picture only since 1997 when I started my journey in medical career. Since then only we got these slings. Before that, birch corpus suspension was the standard of care. Still, a lot of surgeons use that. The results are still not bad, I'll say, because they were working even in past 70-80%, but not all the cases will get cured because the support technically is not from below. It is just pulling from top, and it involves laparoscopy, and it is an advanced laparoscopic surgery which has a little higher morbidity than a vaginal surgery which takes hardly half an hour, 20 minutes.
Any surgeries that you do in uh, atonic bladders?
Sir, atonic bladders, there is no direct surgery to stimulate the bladder. There's no direct surgery. But yes, there's something called sacral neuromodulation, which is coming up. A lot of research is needed still. What they do, they put a sacral stimulator near the sacrum, under the skin. So there are two phases of the surgery in which, this is used also for overactive bladder. This is also for refractory overactive bladder, that we need some stimulators which can sort of restore the detrusor work. I'll say, in India we still don't have experience with these devices because they have two parts. That first will be a trial phase to stimulate the bladder, or to set, let us say, give impulses to bladder so that the overactive bladder relaxes. Atonic bladder, so far, not much of the research is there. In fact, they say it can be done for non neurogenic atonic bladder, where the nerves are still responsive. If nerves are totally dead, then definitely no surgery is going to work. Then it's only the catheterization. But the device itself, the InterStim device for sacral neuromodulation, is in lakhs. And still, there is no guarantee to the patient whether the overactivity will get resumed or this neurogenic bladder will respond. So, experience in our surgical field in this particular thing is very limited. Western people, they do have results. Some studies quote 50% success rate, some say 70-80. But the receptivity in our population, because we also don't have that extensive experience, is limited at the moment.
Okay. We spoke about urethral obstruction once, and I missed asking you. In women, if you see residual volume on ultrasound, and one of the causes might be obstruction, and you said you might need dilatation. What is the cause of urethral obstruction, or what is the cause of bladder outlet obstruction in women? Like in men, it is prostate.
Sir, most important thing which I'll say that if you find a patient with high residual urine, first of all, do a local examination and exclude prolapse, means cystocele. Because what happens many times as clinicians, we are just talking to patient and patient will not say that, oh, I do feel a lump sometime. And many times grade 2 cystocele, patient will also not feel. It's only when we make them strain, cough, push up and do all kind of straining, then only that small cystocele bulges. And you will realize that all the reason, every reason of that obstruction is the cystocele because the bladder has sort of come out. And the moment you correct this, the flow gets better, the residual urine gets better, the frequency gets better, everything gets better because this has been irritating the entire urogenital system. So,
Correct.
clinical examination by a gynec or urogynec is one key factor in women, which every family physician should consider early. That, if a patient after 2 visits to you is not responding to UTIs or is showing high residual urine in sonography, please send it for a gynec evaluation because there can be an unidentified cystocele. And if you go directly for urethral dilatation and if urologist did not correct its cystocele, it is not going to work. Because even if you have opened the urethra, that the bend is still not there, UV angle is still distorted, so it needs correction of cystocele. So that's
Yes.
one very important factor. That in men prostate troubles, in women prolapse troubles. Yes.
Fantastic. Uh, One important thing that we have learned is that if we take a lecture, because of the slightly low attention span of the audience, the lecture is soon forgotten unless we reiterate the important areas or the important points. So I'll just uh, give one line. You have to give one line on that point, right? So
Sure.
recurrent UTI in young people, just in 2 lines.
Maintain water intake. Do not hold the bladder.
Recurrent UTI in the elderly female.
Vaginal atrophic changes. Role of physician to make sure vaginal estrogens are given and residual urine has been checked.
Wonderful. Stress urinary incontinence diagnosis.
Spot diagnosis, only clinical acumen needed, does not need any heavy investigations.
SUI, principal non-pharmacologic therapy.
Kegel's therapy, pelvic floor exercise. You learn first how to teach. If you are unable to convey, please send the patient to us or to a pelvic floor physiotherapist.
Urge incontinence, also known as overactive bladder, principal anticholinergic drugs that you give.
Solifenacin, darifenacin, tolterodin, oxybutynin, and mirabegron. Not anticholinergic, but it is still the first line these days.
Correct. Uh, Overflow incontinence, way to diagnose.
I'll say urodynamics because this is one case where a lot of underlying neurogenic elements are affected. So, urodynamics to establish the diagnosis.
Okay. Uh, uh, I realize that we missed asking you about the indications of urodynamic studies. We, as family physicians and consulting physicians, rarely order a urodynamic study. Tell us the reason to order.
Sir, any patient who a family physician is not able to understand why she is incontinent will need urodynamics eventually, that she is wet. Why? Second is a stress incontinence case which is undergoing surgery. Before surgery, I made it sure that urodynamic is done. Overactive bladder cases where you have already tried 2 medications, patient is not responding is an indication. Third is patient is constantly wet. There is no fistula, but she is constantly wet. That means neurogenic bladder. Fourth is a failed surgery. Somebody did a prolapse surgery, somebody did a urethral dilatation, somebody did some urethral sling. Now patient is to you that we did this surgery and I'm leaking urine. So incontinence post surgery is a very good indication for urodynamics.
Uh, I think I will now open the talk to questions. Dr. Barsha, should I ask the questions? Will you go ahead to ask the questions? Let me know.
Yes, sir, we can start it with the questions. So, would you like me to ask, or would you want to ask the question?
Yeah, yeah, you can ask Dr. Barsha. Please ask.
Yeah. So thank you to our experts for quite a riveting discussion. And there's a lot of doubts coming in from our doctors. So going to take a few questions. So one of the earlier questions that we had, the question is now highlighted on your screen. Dr. Kulkarni asked, old drugs like NFT, uroleucil, metformin are not in use nowadays. What is the reason?
NFTI means it is nitrofurantoin. It is very much in use. I think we need more clinicians to back up this fact that these all medications are very effective. I think unnecessary misuse of monourol, phosphomycin, cephalosporins have really overshadowed these good drugs. I am with you, sir, Dr. Ravindra, that these things they should be in practice. Mandelamin, I am not even finding it available. Urolucil, I'm not sure what is it, but nitrofurantoin is my first line medication. My 80% prescription still contain this, and it works wonderfully.
So next question from Dr. Mulchagnani. What is the role of local estrogen?
A very significant role in overactive bladder urgent continence is in perimenopausal and postmenopausal ladies. It improves the response to anticholinergics. It also improves urethral coaptation by improving the hydration of the urethral mucosa. So, response to your Kegels, your medication, everything improves. So, definite role of local estrogens, but give it judiciously and wisely.
Another question from Dr. Kulkarni. Pyridium, is it urinary antiseptic or analgesic? Also, why is there a discoloration of urine after using the drug?
It's a wonderful drug, sir. I don't know why people don't use it. While it makes urine orange, you need to prime your patient that your toilet will become orange fluorescent color because they get panicky. Especially old patients, they really find it panicky. They say blood is coming. It's not blood. It's the end product, the metabolite of pyridium, which makes urine orange. But it works as a beautiful antiseptic. I tell them it is betadine for your bladder. Let it wash it out. It is analgesic because it is soothing. It eventually makes the urine in such a way that overall the flow improves. It clears as an antiseptic. The bladder becomes silent, and it works beautifully in spasmodic, UTI contractions where the patient is constantly feeling. So pyridium is a very good drug.
So Dr. Madhav asks, urethral chemical, how to suspect?
A patient will not tell you. It is only by clinical examination. Very common finding where urethral mucosa everts out in postmenopausal ladies. Many times we don't even do a surgery for it. We just ask them to apply local estrogen. Unless there is a blockage in outlet, which is demonstrated in uroflow at least, we don't do surgery. It is only by clinical examination you can find it. Also, it gives spotting sometimes. So patient who keeps saying that when I wipe, there is a little blood, please suspect urethral cavity.
Dr. Vishnu asks, I suppose, checking G6PD before anything.
Not as a routine practice, sir. Maybe slowly we will pick it up as a routine screening, but in our Asian patients, G6PD is not that prevalent. But yes, there have been few of my patients who have come to me with telling that I am G6PD. Or maybe they were diagnosed abroad and all. So far in my practice, haven't come across any major issues with nitrofurantoin. But if patient tells me some major effects after nitrofurantoin, poor tolerance, vomiting, and too severe, then I stop it. And then I do suggest that get yourself screened for this.
So, Dr. Vishnu has another question on micturating cystogram.
Yes, sir. Very, very commonly ordered investigation from urology clinics. Maybe for prostate, they use a lot of time because they can actually see obstruction. For me, most of my practice, we know that urethra, female urethra is very short. Second, I don't believe in MCU for a woman because a female is never comfortable passing urine on an X-ray table lying down when we fill the bladder and we ask them to pee. Half of the times, the result may not give me what I'm looking for. My Uroflow, Urodynamic, and post-void residual urine compensate it in a much easier way and less discomforting to patient.
Next, Dr. Nair asks, ma'am, the course of NFT for how many days and the dose?
The acute therapeutic, the therapeutic dose for acute UTI, which we used to write in Singapore, was 100 mg QID. That means 4 times a day for 5 days, which is very poorly tolerated by our Indian patients. So, usual regime which our physicians write, and I'm okay with it, is twice a day for 10 days. The problem is no patient takes it for 10 days. They will leave it in between because 10 days nobody eats antibiotic. Preventive doses is once a night, 100 milligram. If your patient is very thin and you're using it for, let us say, a teenager, 50 mg is also okay. But for a lady, 100 milligram once a night for at least 1 month. Then I prolong it to 3 months based on how many UTI episodes they have had in past.
Dr. Fatima says, can we give NFT during the first trimester?
See, ideally, first trimester, no medication will be considered safe. Category, A category, no medication is labeled. But yes, Niftras for asymptomatic bacteriuria of pregnancy and positive cultures, we do use safely. The safety index has been established that there are no reported congenital deformities. This is still our first choice in pregnancy.
Dr. Madhav asks, is there any role of antioxidant therapy in resistant OAB?
No personal kind of an experience with specific antioxidant therapy, but yes, the cocktail of probiotics with kind of all supplements and some antioxidants is always there. So whenever I give those supplements who have cranberry and other things, usually have these kind of antioxidants. So far, not really established.
So, ma'am, is it okay if we take a few more questions?
Yes, I am okay, provided sir should be okay.
I'm
Not
fine.
hearing
I'm
So, is
fine.
it
constantly
okay?
We have
urinary
won the
thing.
match, so I'm relaxed.
You already won the match. I hope I have passed the viva.
Flying colors.
Oh, thank you, sir. Yes, I'm happy to answer. Will.
So next question, ma'am, the pelvic floor muscle rehab with rebounding training is giving beneficial results without medication.
Rebounding training, I'm not sure what do you mean with that, but I'll tell you if a patient has only mild incontinence, then pelvic floor muscle rehab is actually good enough. But yes, patients, they expect results from you. When they come to me from 30 kilometers and with bad overactive bladder, I'll rather start something. And as your pelvic floor therapy takes over, I'm happy to withdraw. Based on patient profile, I will say how motivated they are. Because your pelvic floor therapy will show results only after at least 6 weeks, 3 months, something like that. I want to make them comfortable immediately in a week first. No? Yeah.
So next, Dr. Sharma asks, chronic urinary frequency on daily night basis before pregnancy, who to evaluate systematically?
Question is a little unclear. Daily night basis before pregnancy. So, is this patient now pregnant or planning to get pregnant? Is my question. And what is the age of patient? Why should a patient have only nighttime frequency in very young age? I'm assuming that this patient is very young. Either she is drinking too many liquids in the night hours, or she is not able to sleep for some reason, and that's why she keep going to urination. I need more details of this case on one-to-one. So you can always contact me, Dr. Vijay, and we can discuss it. Yeah.
So taking the next question from Dr. Jagrati, I want to know the proper management of recurrent UTI of post-menopausal women.
Ma'am, I'm assuming that this patient has proven recurrent UTIs, not assumed UTIs. So there has to have a urine routine, urine culture to prove it. Second, a sonography with pre-void, post-void residual urine, where you get an idea what is actual bladder capacity and how much, whether she's retaining anything or no. Third is put her on prevention, means acute treatment is done. Put her on 3 months of preventive antibiotics based on the culture, whatever last culture has shown. So my first choice, let us say if no culture, will be nitrofurantoin for 3 months with vitamin C in night, and daytime I put them on one alkalizer so that new infection comes with vaginal estrogens. Anytime new infection comes while they are on this, please look into the trigger factor. Have they not drank enough water that day? Did they not sleep properly? Did they overdrink or underdrink? Did they hold urination, or did they took diaper for one day while they were traveling? Or they used public toilet? Though there may not be scientific evidence, there's a lot of anecdotal evidence they do get. So you will find the trigger in these 3 months and work on the trigger. The idea is to figure the trigger and then keep again giving antibiotics and giving quick fixes.
So another question from Dr. Jagrati, what is the amount of urine in post-void condition to be considered as pathological residual urine?
Yes, very nice question, ma'am. The thing is, average body, a woman's bladder capacity on an average during sonography, they can generally hold 250, 350. Young women can hold up to 5, 600. After you pass, it should be less than 50 as an objective value. But to be more precise, it should be less than 50% of what you have passed. Let us say if somebody has passed only 150 and 50 is still inside, then it is 50% inside. It's not okay. So whatever you have passed has to be more. It should be less than 50% of what you have passed, then only I will take it as okay. So somebody who has passed 350 ml and then 50 is inside, I still take it as okay that she has passed 300. It's good, pretty okay, can be worked. But somebody who has passed 75 and 50 inside is 50% inside. That's not okay. So never take it as an absolute value. Look at how much she has passed. But less than 50 can be a rough average for a good report.
Dr. Bhagat asks, role of urodynamics study.
Yes, hello, Dr. Kaushik. It's so nice to see your question here. I'm suddenly happy. Role of urodynamic study is, like I highlighted, there are very clear indications. Whenever there is an incontinence case where you cannot define the cause and your treatment is failing, or you are planning a surgery, or you are suspecting a neurogenic bladder. So these are four big indications and definitely complicated case. Post surgery, some patient has developed incontinence, then you will need role of you will need urodynamic to help you.
Next is from Dr. Shubham. How to give pyridine, the dosage.
200 milligram maximum is thrice a day. Sometimes some patients don't tolerate, so I give them even twice a day, and some patients respond in one dose and they get too scared with the orange color. I tell them stop after two doses. But you can give twice or thrice a day. Max is 5 days, maybe 3 days also.
Dr. Ishita asks, causes of incontinence post surgery or post hysterectomy.
Yeah, now this is a case where again a lot of information is needed. What hysterectomy was done? Abdominal, laparoscopic, or vaginal? Was it a case of prolapse or fibroid? What exactly was the indication? Because let us say it was a vaginal hysterectomy done, then why this patient was not evaluated pre-op for an occult SUI? Because many times once you correct the prolapse, the urethra goes up and now patient starts leaking. A lot of missing information in this. Second is, let us say it was an abdominal surgery, now there is incontinence. First thing is exclude your fistulas. Get a CT urogram done, because there can be a vesicovaginal fistula or uretrovaginal fistula which can happen in a laparoscopic hysterectomy. Let us say it's not a fistula, then I need to look into the catheter protocols, the bladder retention, is it overflow incontinence? Lot of things can happen in this case. We need more information in this particular scenario.
Next, Dr. Pankaj says, I've worked with a physician in the US and found that they take detailed history even for patients with urinary continence. They store the whole history in electronic medical records. But in India, usually in hospital settings, physicians usually refer to OBGYN. What is your opinion on this?
Sir, it's individual place, individual practice. No system is wrong. I'll say they have a tertiary referral unit in place. So they have all the facilities. Somebody will be recording your histories. They give only 10 appointments a day. I practice in that way. All our patient data is with us at any hour of the time. I can always trace back. Even they can lose the file, I can still find. But not everybody I can expect to do that. Our family physicians deal with 100 patients in a day. I can't expect them, poor people, they cannot keep typing and storing it unless they have extra resource. So, what I suggest, I wish I can always work in that kind of environment. But whatever we have, I can tell you, our physicians really work well. They actually remember heart to heart their whole patient's history. Randomly also you discuss with them, they remember more than us sometimes. So, I cannot complain for the system. If given a choice, I would love to work in the system like that. But let's be happy with what we have, and we have brilliant physicians. Yeah.
Next is from Dr. Rajesh. How do we differ clinically the overflow incontinence and overactive bladder in an elderly diabetic?
Difficult situations, sir. That's where you will need urodynamics. Because if you are not able to understand this, there is overactivity symptoms and there is high residual urine also, and patient is constantly wet with no sensation. This is a tricky case where everything is mixed up. They sometimes a totally flaccid bladder keeps on sending their autonomous contractions in between. So there are frequent episodes, there are urgency in times. Sometimes no urine is coming, sometimes they are full. So these are the most complex cases, and eventually urodynamics give a closure. It may not give a treatment, but it gives a closure that it is neurogenic. Don't chase this cat, just put a catheter and let it be on a long term catheter or CIS.
Dr. Tejasri asks, the role of probiotics in recurrent UTI.
It is quite significant, I'll say. All UTIs, let us say, I'll say, giving an example, our gut has so many bacteria, but are they all invading in our system? Answer is no. The vagina has so many bacteria right there. The candida is a normal flora, but are all these organisms invading our system? No, because lactobacilli is our task force. So, any patient who has been on long term antibiotics is very high on junk food, alcohol, their gut flora, chronic constipation. These are the cases where anyhow their gut system is disturbed, and secondary to that, the perianal flora, vaginal flora get disturbed. Very high chances recurrent UTI happens in these cases because local mucosal immunity is not there. So surely, if at least we can do is that insist on them on natural probiotics, dahi, lassi, chach, yogurt, curd, cranberries, but many times food preferences don't allow, lactose intolerance don't allow, then we have got beautiful preparations these days. Something better than nothing. So I don't mind giving probiotics. I'm pro for giving probiotics.
Next is from Dr. Kirti, post LSCS causes of urinary urgency.
Very, post delivery time is always a very tender time. It's like a lot of handling has happened. The duration of labor, the size of baby, the impacted head, the handling can happen. Even the stitch line inside, recovery wise, when the whole family is after you to eat so much, you can't even move, can affect bladder. So these are the cases where pelvic floor rehab comes very handy. Reassurance, handling water intake, telling them Kegels, even with LSCS cases. It works wonderfully for them to improve these urgency. And surely for UTI, with cesarean catheter induced UTIs are very common.
Dr. Monica asks, what is your view on HIFU chair for Kegel exercise?
It's not, I think, HIFU chair. It is EMSLA chair. HIFU is high frequency ultrasound, which is a internal vaginal machine for vaginal tightening. That's called HIFU, which is a different thing. While a chair is EMSLA chair, which has electromagnetic waves which sends to a person when the patient sits, and it directly stimulates to the pelvic floor. It's commercialized in a high way. Technically speaking, I ask a lot of questions on this, that what happens that if you give 10,000 Kegels to pelvic floor in 30 minutes? Is it physiological? Is it not going to affect pelvic floor and cause spasms? So people who are using it, they highly advocate it, though my scientific brain is not able to accept the ideology that how can, overstimulating pelvic floor will really help. So there are not enough studies. Those who have invested in this 50 lakh modality of this chair, they will definitely suggest it. And not one session helps. It is they will take at least 6, 7, 8, 10 sessions, which are expensive. And the thing is, if patient does not learn Kegels, the effect is not going to last. So personally, I feel it can be tried for a small subset of patients, but the effects will not last unless patients' pelvic floor get activated. So chair, definitely, I keep it for a very small number of patients, not for all.
Next, Dr. Rishikesh asks, alkalizing urine with NFT is supposed to make it less effective.
Yes, I won't say less effective because many times you give daytime niftas, nitrofurantoin, and you add sirupcital or alka shot with it. I won't say less effective, but acidic environment make it more effective. So I cannot say that putting alkazol with niftas will reduce efficacy of nitrofurantoin, but I will say that adding vitamin C improves the efficacy, bioavailability. So if I'm giving for prophylaxis and I want the medicine to stay in bladder overnight, give it with vitamin C. And anyhow, vitamin C will improve the collagen and the skin growth inside. Subepithelial collagen gets improved. So they work synergistically. Though I will not say that not don't give cetal with niftas.
Next, Dr. Subhash asks, role of tamsulosin in female incontinence.
Yeah, not in incontinence. Tamsulosin is actually relaxant of urethral muscles, right? We use it in prostate so that flow improves. So not in incontinence for sure, but definitely in female outlet tightening. Let us say I can expect a borderline outlet obstruction, and I want flow to improve. So where a patient is saying my flow doesn't come out, I always keep going. I come out. I feel that there is still more, then I keep going. There it will help a lot because it improves the flow rate to marginal values where borderline high residual urine can improve, but not in incontinence for sure.
So, ma'am, is it okay if we take the last three questions for
As
tonight?
easy ways, okay, not getting bored with my
We,
comment.
no, no, we are okay. But definitely the last three questions.
Last three. Okay. Yeah.
So, Dr. Shubham asks how to examine for occult SUI in prolapse cases.
Oh, yes, you should reduce the prolapse basically first. Now, let us say if it was my clinic, I will put a ring pessary and I'll ask the patient to walk around, cough, show me, is there a leakage? Otherwise, there's something called Boney's test. Let us say you don't have a ring pessary. Once you examine as a gynecologist and you push the bladder up, put your two fingers, one on each side of urethra gently and reduce the prolapse and then ask the patient to cough. Once you have corrected the UV angle, urethrovesical angle, and then patient is leaking, that means there are high chances that after correction of prolapse post surgery, she may get incontinence. So that's the way. Boney's test, or you reduce prolapse and then ask the patient to walk around. Yeah.
So Dr. Shantidas asks, is there any role of herbal or Ayurvedic medicines?
See, I'll tell you, coming from a scientific background, I can't really sort of advocate other pathies, but let me tell you, I'm a very holistic person. We have seen effect of Niri syrup, very commonly used in general practice, which is Ayurvedic preparation. We have seen cystone. We have seen Himalaya products, this product, that products. So I am not an absolutist. I do understand there are a lot of other sciences which may play a role. In fact, a lot of patients of urogynecology have psychosomatic voiding dysfunction. Type A personalities where there's a lot of anxiety, pelvic floor goes under spasm. So we do have patients who have responded to herbal, Ayurvedic, homeopathic, naturopathic techniques. I am happy as long as my patient gets well. There are things which our modern science cannot explain. This is not the platform for that, but definitely I'm not against it. That's what I would like to say.
So we've already discussed about local estrogen, but Dr. Fatima asked, how do we use local estrogen?
They come in form of creams, and the creams come with an applicator. So applicator is like a long tube, and it has markings of 0.5 gram, 1 gram, and 2 gram. Patient is supposed to join with that long insert it in vagina, and squeeze the tube up to that mark. So there's a plunger in it. Fill the medicine and then plunge it. Some people find it comfortable. Some people are very much against it. Old ladies, they don't find it easy. So I tell them, take your finger, take only this size, half the size of your first line of the phalanx, that much, like a pea size amount of the cream. Go in vagina as much as you can and then just smear it circularly. If they have more of urine problems, I say apply it at the entry point of urethra so that after dilatation or any kind of tightness, it softens up. So this is the way. Otherwise, ideally, the applicator has to go all the way in. Based on your patient's acceptability, modify it. And I have told the regime 15 nights in a go, then twice a week for next 2 weeks, and then for next 2 or 3 months, once a week.
So, doctors, in the interest of time, that would be the last question. And there's also, at this point, I would also like to mention that there's a lot of positive feedback for the session. Doctors really seem to have loved it. Thank you once again, ma'am, for
May
this
I have the
amazing
last word?
session. Yes,
May I have
sir.
the last word? Yeah.
Definitely.
Okay. The last word is just a form of compliment for Dr. Naik. Your lucidity, your clarity of thought, your rapidity in answering in a very evidence-based manner is absolutely amazing. I'm very, very glad to have had
Thank
you for my first interview lecture. For the audience, I must tell you that the interview lecture technique is something that I've loved for live lectures, and for Medflix, I'm doing it for the first time, and I hope that you like it. If you do give us feedback, and then the speciality of these lectures is that there'll be no PPT ever, and the experience of the person being interviewed, the expert being interviewed, has to come through, not just the textbook slides. So again, thank you, Dr. Sarita. Pleasure
thank you.
having you.
My
Thank you so
pleasure,
much.
sir. I really enjoyed. Thank you. Thank you. Thank
Thank you so much.
you. Okay.
Thank you, ma'am, for this. Thank you, sir, for leading this very insightful discussion and planning out the whole thing. Thank you once again to both our experts for this wonderful session. And hope to see you again on Netflix. Thank you so much.
Thank you. Thank you. Bye. Good night.
Bye.